Hi, everybody. This is Andrew Gerber, the President Medical Director of Silver Hill Hospital, here to host our first family or community member virtual town hall during this COVID crisis. I am going to be speaking to you with my colleague, Molly Norton, and this is our first use of technology in this particular way. So I hope you will bear with us while we work out any kinks that develop. But why don't we start with introductions? I can't see who has joined, but I can see the total number. So I'm really pleased to see that there is a pretty good group of you out there right now tuning in and listening to me and Molly talk a little bit about what's going on at the hospital during the COVID crisis, and probably most importantly, answering any questions that you have. So let me start first of all by thanking you for joining today. I think this means, if you're hearing my voice, that you were able to download the Microsoft Teams app that we're using to do this. By the way, if you know of anybody who wasn't able to, please have them contact one of us, or you can let us know. We did call a number of people, and we have our help desk standing by to help people. If you've had a chance to play around, you'll see that there's a number of features to this system, but the one that we want to use today, most importantly, is the question and answer or Q&A feature. And the way it looks on my screen, and Molly, you can tell us if it looks that way for you too, is there's a little question mark icon overlapping with a bubble in the top right. And if you click on that, it opens a panel on the right side where I can see any questions that you're posing. And I assume you have a way to see what you're typing and then click submit. What happens is when you click submit, I see the question. It doesn't go out to the whole group. So you can ask, if you want to ask a private question or one you're not sure about asking, you can ask it there, and then I will read the question out loud to everybody and answer it, and I'll click publish, which means everybody can then see the question. If there's anything personal in it, or there's a name or something, I won't use that to protect people's privacy. I'll just read the other part, and I won't publish it if you've put any private information or need to. But in general, hopefully you don't need to include any private information in your questions. Of course, we're available. Molly and I are both available in other forums as well, email, phone, if you'd like to check in with us. Okay, so just for those of you joining maybe a few minutes later, let me introduce myself. I'm Andrew Gerber. I'm a psychiatrist, and I am the medical director and president of Silver Hill Hospital. But now let me introduce you to Molly. Molly, you're on.
Hi, everybody. I'm Molly Norton. I'm the director of patient experience at Silver Hill Hospital, also a licensed mental health counselor. And I'm really happy to be here today to answer your questions. And I'm very grateful for this technology that we have to be able to do this. I am actually reporting from my house, working at home, trying to socially distance over here. So I'm really glad to be here.
Terrific. Okay. Thank you, Molly. So as Molly pointed out, we can even come to you from different locations. I am at the hospital. That's why I'm carrying this mask with me. We'll talk more about that later today. We have instituted a policy where all patients and all staff who are in contact with any other patients or staff are asked anytime they're not alone. So right here, I'm alone in my office right now. Any staff members who can work from home and still perform their functions, and thanks to the wonders of technology, we're able to do that for a number of our staff members, do so. So for example, that's why Molly is working from home, part of everything we're doing. Okay, I just noticed there's a little delay, but hopefully that will go away. All right. So I wanted to start by talking a little bit about what's going on here at the hospital right now. And my hope here is to really convey to you some of the ways that we're being extremely careful and thoughtful about protecting the health and safety of your loved ones, of anybody who is here as a patient. And what goes right along with that is protecting our staff at the same time, because obviously our staff is providing care for your loved one. That's why they're here. And so if we protect one's safety, we have to protect the others as well. So we're really doing both simultaneously. And always during this, we're thinking to ourselves, how do we maintain the same quality of treatment that you or your loved one came to us for? Because there's no point in being at Silver Hill Hospital if you don't need to be here, if you're not getting something from the stay. And so we have been really vigilant about keeping the quality of treatment every bit as high as it is any other time of the year, and have had to be pretty creative in how to do it. And we'll share some of those details with you today. Of course, at the same time, adapting to the changing circumstances, because as you all know, I'm sure you're all watching the news, things change every day, even hour by hour, in terms of the recommendations we're getting from the health authorities, from the local governments, and we are in close contact with both our local and state health authorities, as well as all the recommendations being made to other hospitals and mental health and addictions facilities, of which we are a member. Okay, so let me start and talk a little bit about those things. Then I'll ask Molly to also speak about some of what she's doing from the patient experience perspective and some of the efforts she's been involved in. And then I'll open it up for questions. It is open now, so if you think of something and you don't, you're worried you'll forget, please go ahead and submit the question right away. I won't get to it for another, let's say, 15 minutes or so, but don't hesitate to go and record your question. And of course, you'll also have an opportunity to add questions later on. I'll plan to go till about 2 o'clock. Obviously, if people run out of questions and there's nothing more, we can always stop sooner. But I'll assume that there's plenty to talk about, and both Molly and I want to be here for anything that comes up. Okay, so let me start by talking about some of the basic infection control measures that we're taking. And I imagine some of these you may know from the emails that I've sent a couple emails your way. You may also know it from your family member or loved one who is here. But there's always chances for miscommunication as well. Happens all the time with all of us. So I'm hoping that by going through it, that could clarify any confusion. And then obviously you have the question and answer period to ask those questions as well. So we have been doing a number of things to minimize the risk of exposure of anybody on our campus to COVID-19. And that really starts by restricting access to the campus itself. So as I'm sure all of you are aware, early in the process, we stopped all visitors to the campus. And so that's all of you, as well as any professional visitors or any other reason that somebody who didn't need to be on the campus was here. So you may know we have a fairly large volunteer staff who performs some of the adjunctive functions in our treatment. We stopped those. We also asked any employees who could work from home, and it's actually a fairly large number. I think it's up to close to 35 or even 40 right now out of our staff of 200 plus to work from home, because that was another way to minimize the chance that somebody could bring the virus onto the campus. Now, of course, there are negative consequences to that, in the sense that visits with family members and active family work is a core part of what we do. So we immediately put in place a digital system where all of our patients on the inpatient as well as on the residential or TLP side of the hospital had access to iPads or other electronic means so that they could communicate virtually with families or anything else they had to do. Hopefully that's been working well for you. I've heard good things on this side, but that's certainly something I'm open to hearing about in the Q&A if you have questions or suggestions about how we can do that better. The next thing I wanted to mention is that we did stop our outpatient program. We, under ordinary circumstances, have 3 levels of care on this campus. We have inpatient, we have residential, which we call transitional living or TLP, and we have an intensive outpatient program. And in keeping with standards and with what some of our colleagues are doing, we moved all of the outpatient services to being virtual. So we use the same platform as I'm using with you, Teams, as a way to get all of the patients who wanted to engaged in that process. The only difference is there's different versions of Teams. The version they use, they can see on both sides. That is, the patients can see the group leader, but the group leader can also see all the patients. So that's a little bit different. And that's been up and running now for most of this past week, and changing a little bit, some changes in schedule just to as we figure things out along the way, but that seems to be going very well. It keeps all of those individuals from coming to the campus, and that cuts down on a major source of possible entry points. So that's a big part of what we're doing, but let me keep going. Another issue is the potential for new admissions. Our mission is to care for patients who have psychiatric and addiction needs, and therefore we feel very committed to continuing to consider at least new patients who need our services. Obviously, this isn't a time to come if you can put it off, but as you, I'm sure, understand, many of our patients don't have that option. And so what we did is we instituted a multi-part, exhaustive screening procedure that has multiple ways of keeping any patient who'd either been exposed or certainly anybody who developed any symptoms from getting to this campus. There's even a delay built in so that from the time we first were in contact with somebody until the time they actually get here, we monitor and make sure that they didn't develop symptoms. And if they do, fever of over 100, any upper respiratory symptoms, we don't allow them to come to this campus. Once they come, we evaluate them outside of our buildings to make sure that they haven't developed fever or symptoms since then bring them on, do further evaluations, and only when all of these hurdles have been passed or overcome is a patient considered for admission to our hospital. And we believe that that really reduces to a minimum the risk of new COVID positive patients coming onto the campus. Of course, our staff goes home at night. And so as much as we have restricted their possibility of exposure, our staff are not allowed to travel. Anybody who's had any potential exposures or been in high risk areas has been asked not to come to work. And we also have our staff checking their temperature and logging their symptoms twice a day. So that's a way to exclude staff as much as possible. Nonetheless, we know that there is some potential risk, even who are asymptomatic, carrying the virus. So that is why we instituted the mask policy and have all staff as well as all patients wearing masks. Masks actually are most protective for the other people. So the person wearing the mask is not so much protecting him or herself, they're protecting anybody else from getting it in case they have it. But if everybody wears masks, then everybody's protecting each other. And that's why we made that policy hospital-wide. Now, the big event that happened, just in the last couple days is that we did learn of our first COVID positive staff member. The good news, if there's any good news about that, is that the precautions kicked in. That is, this was a staff member who was last here on March 18th. So that's 8 to 9 days ago at this point. And the first morning she developed a mild fever, she stayed home and has not been on the campus since then. So she had been here the day before, but was asymptomatic. So the chance that she passed it along when she was asymptomatic is lower than if she had been here when she was symptomatic. It's not zero, but it's lower. And the other good piece of news is since that was 8 or 9 days ago, it's overwhelmingly likely that if anybody was going to catch it from her, they would have already gotten it, because the incubation period, as far as we know in the medical community, is 4 to 5 days. It's very unusual for it to go over a week, and this would be even more than that. So we believe that we got it in time. We did learn today that a second staff member, actually somebody who That first staff member also has since tested COVID positive, but again, the silver lining is also stopped coming on the 18th. So it's the exact same patients who would or would not have been exposed and left at exactly the same time. One could speculate that one of them transmitted to the other, whether that was on this campus or not, we can't know, but we do believe that the risk that is going to now lead to more infections on campus is low, given that was 8 or 9 days ago. Another piece of good news to share with you is that in both cases, the illness was very mild. These individuals were only sick for 2 days, had mild fever, and then it resolved. Now, they're not coming back to campus because we still don't completely know how long it takes before someone's no longer contagious, but I am pleased to say that they're both doing well. Of course, what we see on the news and what we hear and are worried about is that in some individuals, COVID is a terribly severe illness. And it's mostly in individuals who have other medical vulnerabilities or advanced age, but it does happen occasionally in younger people, and we're hearing about that now. But it is not the norm, and and I want to be careful that you know that the chances are that these individuals are staff, and again, hopefully it doesn't happen, but if we were to have a COVID positive patient, that the chance that it would be severe is low. Now, cutting right to that, we have not had any COVID positive patients on our campus at all, and we are proud of that and hope to continue that. We do have a very rigorous protocol in place that if any of our patients were to develop symptoms that could be related to COVID, that is either a fever of over 100 or any upper respiratory symptoms, we would immediately isolate them. Only staff using full protective equipment would be around them. So it's not just masks, but face shields and gowns and gloves. And then we would immediately find a way to make sure that COVID is not transmitted to anyone else. And depending on the individual situation, that either would mean moving that individual to another facility that was equipped to care for COVID positive patients, which is one possibility, or having them on an area of this campus where they're not around anyone that they could potentially transmit it to. So that policy is in place. Our staff has been educated with it. It's been distributed on paper, and we are ready for any eventuality in order to protect our patients and our staff as well. So those are really the main things I wanted to share. Let me just quickly look through and see if there's anything I left out. We're working really hard to communicate well, and you can tell us if that's working, but that means we are providing our staff with daily, sometimes more than once a day updates. We're communicating with our patients as much as possible in person. I myself went around to a lot of the houses just the other night when we were distributing masks. We have started corresponding with you as well through those emails and today's virtual town hall. But I would very much appreciate any feedback about what's working and what's not. If you'd like more emails, if you'd like fewer, if you want more of these town halls, if there's some other format, obviously not in person, but way of us keeping you informed what we're doing, we'd be happy to consider that. I hope you see how seriously we are taking this really national catastrophe and pandemic, and all the measures we're taking to adapt to things as they change. So on that note, let me ask Molly to add anything that's on her mind, and then unless something new comes up from that, we will go on to start taking some of your questions. Here's Molly. I think, oh, you're on mute, Molly.
I'm unmuted now, sorry. I just wanted to circle back to, Andrew was mentioning some of the measures we've taken to protect the patients, such as suspending the volunteer services, changing the meal schedules, and I just want to speak to some of the things that we've done to prevent that from diminishing the quality of our program. So in not having volunteers, we've had a lot of talented staff members step up, those with creative skills, to be able to run similar groups to the ones that our volunteers were running. prior to all of this. So, for instance, we have one staff member who actually has a certified pet therapy dog who has amped up his pet therapy visits because we were unable to have people from the outside come and do that. So that's one example. We have a staff member who is skilled at knitting, who's running the knitting groups now, or at least some of them, as many as possible. The meal service, most of our transitional living patients would eat their meals at the main house, and now we are actually delivering meals to them in the houses. So for every way that we've had to make a change, I feel like our teams have done a really excellent job in trying to make the experience still really high quality as well as safe. Another activity that we're going to be adding next week is a needlepoint group. We've offered a free virtual needlepoint session for those who want to learn how to needlepoint. So we're constantly thinking of ways that we can continue to improve despite these really tough circumstances. Patient experience wise, I sent the email out this morning to you all to remind you of this meeting. I just want you to know if you have any questions or concerns at all at any point, you can reach out to me by email. And I can triage your emails to the appropriate people. If I'm not the right person to answer your question, I can get your question to the right person. So I just want to reiterate that. Thank you.
Thanks, Molly. That's terrific. I'm so glad you emphasized the piece about quality, because as I said when we started, that's the flip side. We've got to, of course, do everything we can to protect the safety of our patients and make sure that they're healthy and minimize the risk of spread of the virus. But they're here for a reason. And what's the point if we're not offering really high quality treatment? That's what we stand for. And I'm so proud to say that that's a core part of everything we're doing. So it's different. Molly mentioned some of the things we're doing. There are restrictive aspects. Patients are cross mingling with other patients much less for obvious reasons, but we're bringing as much programming as possible to them, and we very much believe that is maintaining the quality. So why don't we start to go to the questions now, because there are already some great questions coming in, and I think that'll help direct the conversation forward and hopefully also give other folks ideas of things they might like to hear about. So this one doesn't have a name, so I'm assuming it's okay to read out. It says, our daughter was on the inpatient unit the day the staff member with COVID-19 was there. I assume she most likely had contact with that person. How are you monitoring her situation differently from other patients who are not on that unit? So terrific question. And so I didn't mention this, but I will now. The first thing we did once we found out and had figured out who had been in contact is we notified those individuals. And there were no, I don't know if any of you are family members of adolescents, there were no adolescents exposed, in which case we would have obviously notified the family as well. But in this case, it was all adults. And what we told the individuals was that we would be monitoring them extra carefully because we were aware that they had had contact, and at that point it was a week, since with somebody who had since tested COVID positive. Now the good news is that, to my knowledge, none of those individuals, and there weren't that many because this staff member was only in one particular unit, none of those individuals have since had symptoms that are consistent with COVID. So in one case, there was someone whose temperature was still not over 100, but had gone from 98 to 99. So we were monitoring that extra carefully, but everybody was being checked extra carefully. Now, all our patients are being monitored twice a day for temps and for symptoms, but these individuals even more so, because the clinicians, we call them residential counselors in the houses, were aware of who those individuals were and could then keep an extra eye, and the individuals themselves could keep an extra eye. So we'll continue to do that. Given that they don't have symptoms now, it is extremely unlikely that they're going to develop COVID now, because it's, as I said, been 8 or 9 days, and that's really outside the window of what's considered to be the incubation. But you never know, right? And we're learning new things about the virus every day. So for reasons of caution, we did increase the level of monitoring.
Andrew, I could take the second question.
Next question. Great. I'll put you on.
So the next question is, I understand the calls with iPads can only be made in common areas which my loved one finds lacks privacy. Is that correct and not subject to revision? So I'm going to publish that question. So I am happy to look into this. It's a fair point. If you're normally, when we have visitors come in person, there is usually some privacy afforded to most visitation. Obviously, it always depends on the clinical situation and how closely someone needs to be monitored. So I'm happy to look into this one for you. If you want to send me an email on the side, I'd be happy to follow up with you directly on that once I have some more information.
Great. Thanks, Molly. So let me go back to the next question, which we also published. It would be good to elaborate on the protocol that will be followed for the other patients in the same transitional living house if one patient develops symptoms. Will the protocol to be just to wait and see if other patients become symptomatic as well, understanding that testing might not be available, or is that incorrect? Okay, great question. So the protocol is the following. If a patient develops symptoms in one of the TLP houses, and that means a temperature of over 100 or upper respiratory symptoms, immediately they're isolated. So that is, we would start, if they're in a TLP house, by having them in their room. We would bring a doctor, and we do have both a medical doctor on our staff, an internist, as well as a nurse practitioner who specializes in internal medicine. We would bring them in. If not, one of our other MDs immediately would go in protective equipment to that patient's room. If they had a roommate, that roommate would immediately be moved to a different space, and that person would be alone while they're getting evaluated. If that person's medical symptoms warrant further medical treatment, we would then facilitate a transfer to a medical hospital that is nearby, and that would most likely be Norwalk Hospital, with whom we have a close collaborative relationship, because we're not a medical hospital. We're not the right place to be treated for COVID if the symptoms become serious. If the symptoms were not serious, and obviously potentially serious because everything with COVID is, but that is, we didn't yet know if they had COVID and the symptoms were relatively mild. The next question would be, how severe are their psychiatric symptoms? Because if this is somebody who could go home in a safe way and their families were open to that and it felt like the appropriate intervention, that would be the next step at that point, because it would be a way to, again, isolate that person in a space that doesn't have other patients. But that would obviously be not a quick decision. Families would be completely involved and have a lot of choice in the matter. In the third situation, which is they don't have acute medical symptoms, or at least they're mild enough that they don't need to go to the hospital, and they can't go home for whatever reason, then we need to move them to an area of this campus where they're in isolation. And we have a number of areas of the campus that we're holding in reserve to do that, where they could be treated either alone or only with other patients at risk for COVID. Ideally, it would be completely alone, and then with staff who are in full protective equipment. So we have those standing by and have not had to use them, thank God, but if we did in that third case, that they would not stay in the house. Now, you could ask, well, what's going to happen to other members of that house who now have a potential exposure? And the answer is, we can't reverse that, but what we can do is keep that group from interacting with anybody else, which we're already doing. The houses don't interact with anybody outside that house. So we can't split every member of that house up, but we will keep that house together and vigilantly look to see if anybody else has developed symptoms. Because that first person, we got them out of there as soon as they became symptomatic, the time that they spent symptomatic with the other patients is small, maybe even non-existent. So we're hoping we minimized any potential contact. It's not just the level of how symptomatic someone is that determines how likely they can pass it on. It's also how much time you spend with somebody. And don't forget, they're all wearing masks, so the chances of aerosolized or droplet spread are minimized, given that everybody's using masks as well. So that's really the reason for what we're doing. Now, of course, for symptoms, we will then immediately do our best to get them testing, because as far as we know, we can get testing for people who are symptomatic. If at that point testing is available for those who are not symptomatic, we would absolutely do that. The last I heard was that it wasn't available for asymptomatic patients, but we'll continue to evaluate that constantly and let you know if and when that changes. Okay, back to new questions. And I think I'm going to ask Molly to take this one as well. Molly's the one about the groups and the common area. Do you want to take that one?
So I'm pretty sure you answered this, Andrew, in your very detailed explanation that you just gave. But the common areas within the house, again, the patients are only with people from their own house and program. So unless someone has been identified as someone who is symptomatic, there are common areas that are going to be shared. Of course, people are trying to maintain the 6 foot distance, and people are wearing masks. We're doing everything we can. You know, given that our programs are heavily group based, we can't separate everybody and be giving individual programming to each person. It wouldn't be therapeutic or conducive anyway. So I think we're taking all of the measures that we can in keeping people safe and keeping them with limited contact with people, actually no contact really with patients from other programs.
Great, thank you, Molly. And so the next question is, and I just published it, is are you quarantining the patients that did have contact with the infected staff persons? So the answer is no. That it's a small number, but the patients who we knew overlapped with the person who was last here on the 18th, or the 2 people who were last here on the 18th, are not being quarantined. And that is because the amount of time that has passed since they were in contact with that person is so long that it exceeds the incubation period as we know it. So we prioritized, we only have so much space on campus, and we've prioritized the reserving the extra space right now for the quarantining of anybody with symptoms, and have not used it for individuals who were in contact with that staff member. The other piece would be, though, that those patients, if we did quarantine them in that way, frankly, it would be impossible really for them to take advantage of the programming. So if that was something that an individual wanted, I would recommend exploring whether it might be appropriate to discharge at that point, and certainly we would be open to that discussion. I hate to see someone leave when we can help them, but on the other hand, of course, we have to respect everybody's level of comfort with the situation, and we can be in personal contact about that. Reach out to Molly or to myself or to your treatment team, probably best of all, about what to do if that's your situation. Okay, so I think we have made it through the 5 questions. Really terrific questions. You know, one of the things I'd love to hear, and I don't know if somebody wants to put it into a comment, doesn't have to be a question, or wants to send it to us separately, but I'd love to hear whether this event, this virtual town hall, and or the couple emails we sent out were useful, because we can do more of them, or we don't have to, depending on what people think. We did have up to 20 attendees today, so I'm hoping that means that people were interested in this, but I'm also wanting to hear feedback about whether this was useful or not. We do have another question. Let me look at quickly. The contact with the same group members every day limits the information and experience exchange as compared to normal circumstances, reducing the effectiveness of the programs. How can this be improved? Well, it's a great point, and let me comment on it, but then I'll also ask Molly to weigh in as well. There's no question that is an impact, right? We wouldn't do all the contact with other programs that we do under ordinary circumstances if we didn't think there was some benefit. So changing that because of the virus is not optimal. The challenge would be, how do you weigh that against the risk of intermingling? And the way I read your question, you're challenging us to think creatively about this. And I'm really thinking out loud right now. But one of the things that comes to my mind is, could we create virtual interactions and experiences between houses using those same iPads that they're using to contact all of you, as a way to share experiences between houses? And I'm curious whether that sounds like it is worth exploring. Maybe Molly, you might want to comment, and then I'm happy to pass that along to my Chief Clinical Officer, Dr. Grote, to explore if that's something that people think might be helpful. And let me put you on, Molly, and you can comment on that and anything else.
I think that's a great idea. And my thought on that would be, let's talk to the patients and see what they think would be helpful. If we're able to set up virtual ways for them to spend time together, or have groups together, or mimic more our regular process. I would want to ask them, their feedback before we make any changes there, just to make sure that we're not, making decisions for them and that they're involved in that. The other thing I want to add, just from a patient experience standpoint, and being the person who receives a lot of feedback from a lot of different programs, is that oftentimes we have people who would prefer to keep the programming more to their unit or house. It's not uncommon that people say, sometimes having the other groups mixed in can be difficult because of the different challenges that people have. So in one perspective, not to say that we're going to go back to, we're not going to change this permanently. I'm sure we'll go back to the way we were doing things before, but for some people, they do find benefit in having groups with their peers. So I just want to add that perspective.
Terrific, thanks, Molly. So we have two more questions, or one's a comment, one's a question. First one, the event was helpful, and I really appreciated Molly's email, and especially her call. So thank you on behalf of Molly and myself. We're really pleased that this was useful. I'm thinking this is a weekly thing that we'll do, and that we'll plan to do it again next Friday, but I'm open to suggestions. If you wanted to do it sooner or later, or at a different time or day, all those suggestions are welcome. As Molly points out, when you want to help people, the best thing is to ask them what they'd like, not assume you know. So I'm really open to what people think, and don't have to worry about feeling like you're speaking for everybody, because everybody's got a right to replies. So if I get different answers, I can balance them. But please do let us know, either through the Q&A or through email to Molly or me, what you think about that. Next one, will you be open to considering discharge a bit sooner than ideal to balance psychiatric and contagion risks? With all outside programs and care arrangements also disrupted, how can families, patients, and clinical staff work to develop viable alternatives? What a thoughtful and wonderful question. So absolutely. In other words, time of discharge is always a complex thing. And, we have used in our history a kind of general 28-day for our TLP programs, and a little different for some of the other programs, standard, because of a kind of a convenience. But there's nothing magical about those numbers, and you have to balance it with the other issues. So contagion and the risk is absolutely something worth considering, and we'll have to work out the details on our end, but I can assure you there'll be no penalty for an early discharge, and if that makes sense given the situation. And again, it's a case by case. We'll discuss with you, but I can't imagine any reason we wouldn't respect your family members' wishes in that regard. What you say about the disruption in the outside programs is absolutely true. I'm on a number of listservs with my colleagues in various institutions, and I can see how different programs have changed. Some are canceled, some are virtual, some have changed their schedules. Many, if not most, are not taking other new patients. It's very complicated out there. And our staff, particularly our case managers and social workers, are working very hard to try to stay abreast of all these changes, so that when discharge comes, we can give you the best advice possible. I did mention that our IOP, or intensive outpatient, if it's an option for you, or your loved one, is still open. And we are actively, I think we've taken 12 new patients just in the last week into that program from our programs. We're prioritizing our own programs. We may open it to folks from other programs, but right now it's only open to people coming from residential and TLP. So that's absolutely an option if that's something you'd like to explore. And we'll do our best to work with you. And things are going to change because what's today is different than what will happen on Monday. And as you can imagine, this is, most clinical programs are also small businesses, and how they're able to cope and survive through all these changes is very complicated. So we'll do our best to help you. And then one more question. My loved one is due to complete the 28-day program in early April. We know that IOP programs are not offering in-person treatment, but rather virtual. Is there any thought on extending the stay? Another wonderful question. And again, the answer is absolutely yes. So I think we need to make sure case-by-case basis that it's appropriate for that individual. But again, I can't think off the top of my head of any reason why we wouldn't be open to extending the stay of somebody for whom the IOP options are limited. Because, frankly, virtual is better than nothing, but virtual is not as good as in person. So that's certainly something we can look into, again, on a case-by-case with your loved one. So you can reach out to the treatment team, probably makes the most sense. Reach out to me or Molly, and we're happy to get involved and help. And we'll let the treatment teams know all these answers. We're going to publish all these questions and answers to our treatment teams so they know what you've asked and what we've answered. So you're not, well, Dr. Gerber said this or Molly said that. Rather, they'll know exactly what I said and Molly said.
Andrew, just one thing, I think it's important to mention that under regular circumstances, a lot of times our patients do extend their TLP stays, so it's not uncommon for someone to stay longer than 28 days. And I think our programs are well equipped to handle that extension, and that if it's clinically appropriate, we do believe that that person would benefit from that extra time. So that's a great question.
Great. All right, so another nice comment. I want to echo the earlier comment that this is helpful as an efficient way to disseminate information. Thank you. This is waxing a little, just sort of, not prophetic is too strong a term, but one of the things that's on all of our minds, I think, right now is what's the future going to look like? Because this really unprecedented event, I think, has changed the way we interact with each other. And it would not surprise me if there is a sharp uptick in the use of virtual means for providing certain kinds of services. And I can just tell you from my own experience, I never did a virtual town hall before. I've never communicated with my whole staff or all of our families this way, but maybe we should have. And maybe this is something, again, it feels a little early to call anything a silver lining, but in a way, maybe this is a silver lining that we're learning that there are ways to communicate with one another that we can continue. So if this is helpful to people, it may be something we do in an ongoing way. A couple more comments. The session emails have been extremely helpful during a challenging time. I would plan for weekly sessions and sooner if needed, as the situation is rapidly evolving. Let's plan for weekly. I think I'm comfortable saying that. And of course, if anything develops sooner than that, we can schedule something sooner. It's always easier to get an email right away, and that we would do within hours if something were to change, but then we could give you notice about a virtual session. Education regarding antivirus hygiene, social distancing, and any other present health protocols at their homes. Great question, really terrific. And the answer is yes, but you can always do more. So, in some ways it feels like ancient history because it was like, but when we first learned about the virus, our emphasis was on, with our staff, was on, exhaustive hand washing and even better hand washing than Purell. But if there's soap or water, then use Purell. Not touching your face, and being on video, I'm consciously aware that there are moments I still touch my face, and I work very hard not to. but it's something we all do, and we know it's one of the vectors for how the virus is getting in. Um, uh, let's see what else. Avoiding any situation, as I'm sure any of you who are in the area are aware. In nearby Westport, not far from where I live, there was a party early on where 40 people got infected. That is, so forbidden right now, and our staff knows that their first and foremost job is to protect our patients, and that means refraining activity at their risk. So has that a lot with them. We haven't had any staff members on planes in a long time because we early on said that staff members do that, or if they did, they had to be home. And it's a good reminder though for me, because with everything else going on, it's a chance for me to reemphasize that with the staff and with the patients too, because they have to follow these protocols. One thing that I didn't think to say until now is we have a fantastic housekeeping or cleaning staff here, and I have actually been meeting with them very regularly. And you might say, what's the president meeting with? And the reason is they are so dedicated to keeping this place safe, and they have increased the frequency and intensity with which they clean all surfaces dramatically. And of course, they're not people who can work from home. They have to be here in person, and so they're using protective equipment, but they are so dedicated and not calling out and coming to work and worrying about things. I have to say, I'm another group that has inspired me in the level of their commitment to keeping everybody at the hospital safe. So it's again, the small pleasures of seeing your staff really dedicate themselves to their work and to put the mission of the hospital, which is to keep people safe and provide care, at the center of everything they do. And that makes me very, very proud and able to come and speak to you with confidence. Molly, why don't I put you on for maybe a little chance to say goodbye, and then we will make some closing remarks, and then let people know about next time.
So just want to add one thing about the housekeeping staff. They're also incredibly kind to our patients, and that's something that's been consistent over the years, and our patients give us feedback about. Is just they do an excellent job, but they're also excellent people and are really, really kind to our patients. So we thank them for that as well. In terms of wrapping things up today, I'm so glad we did this. I'm so glad that people found this to be valuable, and I really hope that we do this again, and we continue to have an open dialogue. I think it's really important under normal circumstances and difficult ones to allow a forum for people to ask their questions and have them answered timely and efficient. So I'm so glad we could be here. Again, if you think of anything after this, you have my email address. Please feel free to reach out anytime, and I'll get back to you as soon as I can with any information that I have. So thanks again.
Thanks, Molly. So let me just add my own thanks to all of you. It feels really good to be able to talk to all of you about what we're doing and about the care we're providing for your loved ones. I'm sorry I'm not able to see you in person, and I'm sorry the way the technology works, there wasn't a good way to see you all even on camera. But I hope you got something out of this. Let's tentatively plan for the next virtual town hall to be 1 week from today, same time. That is next Friday, April 3rd, 1 to 2. And if anything changes, we will of course let you know. We'll also send out a reminder to everybody in our next email. And then, if possible, make some phone calls as well. So we will keep you all up to date. If before then you think of other things that we can do to help, either in the virtual town hall or with your loved ones, or answer any questions, please don't hesitate to reach out to either Molly or myself. Hopefully you have both of our email addresses. Molly's is mnorton Molly Norton, it's the first initial and then the last name, at silverhillhospital.org. And I am A. Gerber, A-G-E-R-B-E-R, at silverhillhospital.org. We would both be happy to answer questions or to send your questions to anybody else who's better suited than we are. We really feel passionately about being responsive, and particularly at a time like this, but really at any time. So maybe we're onto something we're going to do in the future. I do see a last question popped up, which is great. What about family support groups? Good question. Molly, do you have a thought about that?
Yeah, I could speak to this one a bit. So I know that in terms of the regular clinical family sessions that we have with family members, those are mostly virtual or phone calls at this point. In terms of family support groups, Susan DeRosa, who oversees all of our family program, is actively working on a plan to address this and allow for more family support groups to make up for the loss of not being able to come here for on-campus meetings. There's also a variety of Al-Anon and other meetings that we can't host on our grounds right now. So I know that Susan is really working on this feverishly, and as soon as we have more information about that, we will be the first to let you know. So in process.
Great, thanks, Molly. I can't resist bragging for just a second. I just feel so lucky having people like Molly, like Susan, like our nursing staff and our therapist staff, and really everybody who works here as my colleagues. I mean, I think it's just an enormous privilege to work with people that you have such confidence and trust in. So I hope you feel that too, and I believe that when you interact with them, you'll see that. Thank you. I'm glad we could be here today. And let's be in touch, and I will see you again next week. Stay safe. Bye.
Bye.